Hi, I'm Dr. Charles Cobbs. I'm going to present a case today for patients and family members and students who are interested in brain tumors. The lady that I'm going to speak to today has a recurrent malignant astrocytoma. There are a lot of words when you talk about brain tumors. If you talk about brain tumors in general, most people think about malignant brain tumors, which are the kind that come from the cells within your brain. If you just talk about the most common brain tumors that go to the brain, it's really metastatic tumors that come from places like the breast, the lung cancer, melanoma. And then there are tumors inside the skull called brain tumors that are even more common, but they're called meningiomas. These are tumors that come from the lining of the brain, which is called the dura. But what I'm talking about now is a malignant brain tumor, and a patient who presented with one about a year ago that was tiny, and we biopsied it, and then she got treatment. So what is a malignant astrocytoma? Well, the terminology gets confusing, and the patient actually stated to me that she was told she had an astrocytoma, and then I called it a glioma, and she got confused. Basically, a glioma is a broad category of tumors, and I'll write it up here. Glioma means a tumor that comes from the glial cells in the brain. There are different types of glial cells in the brain, and they can all cause tumors. One type is called astrocytoma, astrocyte. The other one is called oligodendrocyte. And the third one is called ependymoma or ependymoma. So the three different types of glial cells can cause different types of tumors. In adults, we get the predominant form being astrocytoma. So what is an astrocytoma? An astrocytoma is thought to derive from the astrocytes, and actually what we think happens is if this is the brain here, this is my poor drawing of the brain. Inside the brain there are areas called the ventricles, which are where spinal fluid lives inside the brain, and on the areas right around the ventricles there are cells, and these cells are right inside a layer called the ependyma, and they're called subependymal cells. These cells are thought to be stem-like cells that throughout your life will divide and then send cells throughout your brain, especially in the frontal lobes and the temporal lobes. And these are the areas that have the highest predominance of these subependymal stem cells. That's the frontal lobes and the temporal lobes. And that's actually where we see most of these astrocytomas occurring. So let's say you have a stem cell in that area of the brain that is mutated. It's going to be at a higher likelihood of becoming a cancer cell. And indeed, there are actually research papers that show that early mutations in these stem cells in the subependymal zone around your brain are the same mutations that are found later on when a tumor may show up down here or up in this area of your brain. In adults, we get basically two types of tumors that come from astrocytes. We get astrocytomas, and often they'll start out as malignant brain tumors right off the bat, and these are missing a mutation called IDH1. This is a key mutation that seems to divide all astrocytomas into two groups. If you're a younger person, you have an increased likelihood of having an IDH1 mutant tumor. And these, instead of becoming grade 4, which are bad, that also is called glioblastoma. The IDH1 mutant tumors usually start out as lower grades, called grade 2. And then over time, they slowly evolve more and more mutations, and then they can become a grade 3, and then a grade 4, which is glioblastoma. So it's important to test these genetic components of the tumors when you have a patient to see if you're going to predict if they're going to have a slower evolution of their tumor from a lower grade to a higher grade. Most of the time in adults, when they present with a high grade glioma or a glioblastoma, they have a wild type, which means normal IDH1. It's not mutated, and it's a worse prognosis. Another thing that we study when we look at these tumors is something called methylation. So as we talk to this patient, we're going to talk to her about the drug she got. She had a drug called temozolomide. And what is temozolomide? It's a drug, if you look at your DNA, let's say you have DNA, the genetic code ACTG. Well, temozolomide is a drug that comes along and it puts a molecule on the G, the guanine. And if your body has another way to get rid of that, it can come in and take that molecule off, and then basically the chemotherapy doesn't work. And what is that thing that does that? It's called methylguanine methyltransferase, or MGMT. So if you have a gene, and a normal gene and protein called MGMT, then the standard chemo for malignant astrocytoma or glioblastoma doesn't work quite as well. If you don't have this, in other words, if there's something that's blocking MGMT, then this chemo molecule sticks on your guanine, and it makes the DNA of the tumor fall apart, and it kills the tumor cells better. So if you have a methylated gene for MGMT, then that means the MGMT will not make the protein, and that's a good thing. So if it's methylated, you don't make the protein that gets rid of the chemo works, and it's better. Unfortunately, about 2/3 of people with glioblastomas or high-grade gliomas, especially if they are IDH1 normal or not mutated, will have unmethylated MGMT. And that means this protein can go up here and inactivate the chemo, so that even though you're getting chemo, it's not working, and the tumor survives better, which is bad. So if you look at the survival of people with glioblastoma, about 15 years ago, a discovery was made that was published in the New England Journal of Medicine that showed if you took all the people with glioblastoma and looked at their survival, if they got temozolomide, which is the drug that makes that molecule, the survival at 1 year, 2 years, 3 years, if the general survival was 50% at 1.5 years for glioblastoma, if they had a mutation of MGMT, a methylation of MGMT, which means if they were able to keep that drug on their tumor cell DNA so that it worked better, then they actually lived substantially longer with their glioblastoma. So these are some of the things that we think about when we have patients with malignant glioma. This lady came in with a tumor that was a grade 3 astrocytoma on the original biopsy. I operated on it yesterday, took it out after it came back, and I suspect it's either going to be a grade 3 or grade 4 because the natural progression is to get worse. She did not have the methylated MGMT, and I believe her tumor did not respond too well to the chemo, as you would expect in that case. I don't believe she had IDH1 mutation either, so both of those things give her a worse prognosis. So what is the standard treatment for somebody with a malignant glioma and or glioblastoma? So what we do typically is if someone presents with, for instance, a seizure, which was the case in her case, SZ stands for seizure, and this is the timeline. What we do is we admit to the hospital, we get an MRI. The MRI might show that they have a tumor, and then what we want to do is get a biopsy or do the resection of the tumor as soon as possible. So in her case, she had an MRI, and with a few days, she had a biopsy. I'll abbreviate that BX. That showed that she had a grade 3 astrocytoma. And then the standard treatment for that type of tumor is to give someone 30 days of radiation treatment broken down into 5 days a week for 6 weeks. So after about 3 weeks after the biopsy, once you get the diagnosis, you start radiation treatment, and that's 1, 2, 3, 4, 5, 1, 2, 3, 4, 5, 5 days a week, and this goes on for 6 weeks. So every day you go in for about 30 minutes for your radiation treatment. 4, 5, 6. And for each of these first few weeks and months, you take a drug called temozolomide, TMZ. So you're taking that every day during the week as well. So she took temozolomide, and she had the radiation for the first 6 weeks after starting her treatment. She was then supposed to stay on temozolomide after that, but she wanted to pursue some non-traditional treatments. Unfortunately, the tumor came back more aggressively. It started out just as a little tiny spot up here in the right parietal area. So the first surgery I did, if you take this model, was I made a little hole in the bone and went down and took a biopsy here. But the tumor came back, and so yesterday I took her back and I made a more extensive opening, and using stereotactic guidance with a computer GPS system, I took out all the tumor in that area that had come back. And we will see as we interview her how that went. Fortunately, the surgery went well, but the flip side is that we've exhausted the radiation and the chemo possibilities. And in her case, one of the goals of the surgery was to decompress the pressure, but also to get tumor tissue that we can analyze and send to one of multiple companies that can analyze the genetics and look for mutations that might identify certain pathways that we can target with drugs. So that's where we are with this patient, and here we go to meet her and to see how she's doing less than 24 hours after her second surgery for her anaplastic or grade 3 astrocytoma. Thank you. Hey, thank you so much for allowing me to interview you. I'm doing a bunch of series of case studies on different types of neurosurgical issues, and I wanted to talk to you about talking about your case. About a year ago exactly, you had a horrible seizure, didn't you?
Yes.
And you came into the hospital and we got an MRI, and there was a spot on the back side of your head on the right, in the right parietal area.
So that's this part.
Yeah. And tell me about what happened when you had that. Just briefly, what happened?
So initially, we almost thought it was a stroke, me, my husband, and myself. But through my thighs, it was like they were vibrating like a wave. And it was so scary. And I was telling him, make it stop, make it stop. And he says, should I call a doctor? And of course, everyone always says no. But eventually, so we went to bed, and he was watching me. I fell out of the bed, and I was shaking a lot and all that. But I was talking to him and conscious, but I have no memory.
Okay.
So he called 911, and they got me to the ER 3 miles away. And I was put on a ventilator. So the seizure was stopping my heart from acting normal. And the ventilator required anesthesia. So that was either 30 or 34 hours that I had that in.
Yeah.
And then we just progressed from there, going to neurologists and hematologists and getting MRIs and CT scans.
And then they sent you to see me, right?
Yeah, the main neurologist had you come in to do a biopsy initially.
So let me show you what we did then. Okay, here is the MRI that you had back a year ago. And this is the front of your head. This is the back of your head. This is the right side. And when they gave you contrast, everything was normal except this one little spot lit up right there. See that white spot right there? Yeah. So I did a biopsy. I went in with a little hole in this bone and took a little tissue, and they said that that was a grade 3 astrocytoma.
Yep.
And the treatment for that is radiation 5 days a week for 6 weeks.
Yeah.
Plus temozolomide as a drug you took once a day for 6 weeks, and then after that you took it for 5 days at the beginning of the month, right?
No.
Oh, you didn't do that?
I didn't do that part. That was, I think, recommended. I wasn't sure which drug it was, but it was something for 5 days and 23 days, but I didn't get to that part yet.
You did some alternative treatments, right?
Yep.
And then time went by and you started getting sick again, right?
Well, this tumor, at first it would go down a little bit each MRI. Like if it was a 1.2 millimeter, it went to 1.1. Yeah. But then, and most recently, it went the opposite way, and there was growth.
Yeah.
And the neurologist, seeing the growth, then recommended the PET scan.
Yeah, let's go to look at that now. So you had a PET scan because they saw this change in the scan and they weren't sure if it was from the radiation or not. And this is the PET scan where they injected you with a kind of chemical called fluoride glucose. So the glucose that goes for energy in your brain is taken up, and normally in the brain you see glucose is taken up in the cortex, but when we got to this spot it was really bright, and that indicates that there were probably tumor cells there, and actively growing. And during that year, unfortunately, that little spot had grown into a big portion of tumor consistent with actively growing tumor, and it was compressing these structures all around it and pushing your brain across from the right to the left. So this side's getting pushed over that way. That's called midline shift. And since you had depleted all the chemo and radiation options, we talked about operating on it. So we took you to surgery yesterday, and I went in here and removed all of that. Now you can see that on the post-operative MRI, where is it? right here, that all that tumor that was there's some blood here, but essentially all the tumor that was there, I was pretty much able to remove it yesterday. So you are less than 24 hours out from your surgery yesterday.
Yeah.
Can I look at your incision?
Yeah.
It looks pretty good. We have staples there, and those will come out in about 2 weeks. The tumor was pushing on part of your brain that controls movement to the left side. Can you squeeze my hand here? Everything's working pretty good. How are you feeling on a 1 to 10 scale? Do you feel sick or headachy?
I feel really good. I could have in this area or this area some pain, but the Tylenol really takes care of it.
Okay.
And I've been worked with the OT and PT this morning already, and they watched me walking and brushing my teeth and doing stuff normal like any person. And over this many months, not the whole year, but I had some smaller seizures, and I did go to ER a couple times, and there was a medicine I could take that would stop the seizure like immediately.
Yeah.
Or if it didn't within 10 minutes, then I was supposed to call 911. But it's just scary and thinking like, why am I still having seizures? So prior to this operation. And you know, so that was just kind of scary. What's going to happen? Is it going to keep growing?
Yeah.
So that's why when the surgery was recommended, even though that seems really scary, then that I did that. And yeah, it's just incredible. Less than 24 hours. The worst part, I had to be here at 6:30 in the morning, which
Well,
I'm not.
if that's the worst part of the surgery, then that's not too bad from my perspective.
Yeah. And because I'd been under anesthesia, I knew I tolerated it and wasn't allergic. And so I could visualize seeing myself coming out so I knew that would be okay. And I was just concerned like the future. And every question I asked you, you gave me a very, very low percentage of that possibly happening.
Yeah, we talked about the risks of surgery: infection, bleeding, stroke, etc. Usually about 1 or 2% risk. Now, we will have to keep you on a seizure medicine, and we will keep you on dexamethasone or Decadron, because you still have a lot of swelling, but that swelling should go down, and we'll taper you off of that over the next few weeks. And we'll get that tumor sent out for analysis for pathology and for genetics. We're looking to see with what's called NGS, which is next generation sequencing, whether there might be some mutations that would allow us to give you a specific drug to target your tumor. So other than that, I will be seeing you back in a couple weeks to take the staples out, and the neuro-oncologist will be seeing you to talk about further options, okay?
Yeah, and I'm sure I'll be still having the regular MRIs.
Absolutely.
So at the very beginning, after the biopsy and knowing what it was, he said I would have MRIs every 2 months.
Right.
Which I have been doing.
Well, I want to thank you so much for letting me interview you. I think you'll be very helpful for other patients to see what it's like to have brain surgery. You look like a model case. You're going home within less than a day from a big brain surgery, but you sailed through it, and hopefully everything will continue to go well, okay?
Yeah. And I was able to eat last night dinner.
Okay.
I told him, well, I might feel like my energy's drained. He's like, no, you need the calories. But let me ask you a question I asked you already. So most of this swelling was like the old swelling and probably from radiation. But right now, so you removed some of that swelling, but obviously from the operation, there probably will be new swelling.
Yes, so I took out a lot of tumor, and when the tissue around that settles down, the swelling will go down.
That's the old swelling.
That's the old swelling, but there's also a little swelling that'll kick in for 48 hours due to the surgery itself.
Okay.
But I'm hoping that in 2 or 3 weeks, all the swelling will be dramatically improved.
Okay.
But we still have tumor cells around where I took the tumor out, and we have to keep fighting this thing, okay?
Yeah, because that's like the mutation of cancer.
Malignant glioma is a tough disease, and yours was a
This
great...
is the first time I'm hearing glioma.
Well,
I before only hear astrocytoma.
Well, astrocytoma and glioma are words that are used interchangeably.
Okay.
but astrocytomas can be grade 2 in adults, grade 3, and grade 4, which is glioblastoma. So we're going to have to look at it and see what it is and get you the best treatment from here out, okay?
Okay. I know it started as a 3.
It started as a 3.
So this testing is going to clarify further.
Right.
Okay.
Okay. Well, thank you so much for participating.
Okay.
I'm sure
Thank
a lot
you.
of
I know you did
patients
a good
and
job.
family members are going to appreciate you being so willing to talk. Okay.
Yeah.
Thank you.
Thank you.
So our patient was very nice to let us talk to her right after she had brain surgery for her tumor that recurred on the right side in the parietal area. I had taken her to surgery the day before I made the first video and resected that large component of tumor. We sent the tumor to pathology, and this last video will show you that during our tumor board conference, which is a video conference now, the pathologist goes over the classic findings of the tumor. Under the microscope, it has the classic findings of what is now grade 4 glioblastoma, which is areas of necrosis surrounded by what's called pseudopalisading cells, where there are intense areas of growth, and then little blood vessels called microvascular proliferation, all consistent with this tumor having gone from a grade 3 to a grade 4 glioblastoma. Still at this time, we have her tumor genetic analysis being performed. So this lady will be getting further treatment if possible with a different chemo drug, or possibly with a targeted inhibitor if we find a specific gene pathway we can target.
So this is the tumor here, and it's hypercellular, and there's parasitic necrosis, and down here is the microvascular proliferation, and I cannot show very well here, which we have quite a bit of mitosis as well, like 30 mitotic figures per high 10 high par field. So this is glioblastoma, and it's IDH1 wild type, ATRX wild type. So this is WHO grade 4 glioblastoma.